Hi everyone. The topic of today's module is the subject of canine uroliths, which I'm sure you're all dealing with on a regular basis. So first of all, we need to consider what a urolith is. It comes from the Greek, two Greek words, uro meaning urine and lith meaning stone. And the stone itself can be made up of different portions, so it doesn't necessarily need to be one mineral type, which is the entire stone. In fact, my experience is that compound or mixed uroliths are perhaps more common. So here we can see on the diagram on the right-hand side of your screen, we have the central core or nidus of the stone, and this is the central region where the stone formation starts. We then have the main body of the urolith surrounding that, and then finally we have a shell which surrounds the body of the stone, and we can also have surface crystals which are an incomplete covering on the outside of the stone. So it can be made up of several different types of mineral. As far as composition is concerned, as I say, it's possible it could be one type, but mixed uroliths or compound uroliths are something we see fairly frequently. And a mixed urolith is made up of less than 70% of a single mineral type, whereas a compound urolith is a urolith that's formed up with a nidus of one composition, and then one or more surrounding layers with different mineral composition. And these compound uroliths form because factors that initiated the deposition of one mineral type are superseded by factors promoting a different mineral type in that particular patient. Diagnosis is usually made using imaging, and sometimes we need to use a combination of different imaging types. Obviously, if we have a radiodense stone, then plain radiographs are going to be very, very good for that. Whereas if we have radiolucent stones, then contrast radiography or ultrasonography may be more appropriate. So looking on the table on the right-hand side of your screen here, we can see that obviously if a urolith is fairly radiodense, then radiography is going to be the most useful tool. Radiography is also going to tell you more about the shape of a stone than ultrasound would, and also give us an idea of the surface contour of the stone and the general diameter and dimensions of the stone. It can also tell us quite a lot about the number of stones present. We can be more accurate about the number of stones we're seeing and their position. We can also see stones within the kidneys, ureter, bladder, and urethra. Now, if we compare that to ultrasound, ultrasound still compares pretty well, but it doesn't tell us much about the radiodensity. It doesn't tell us anything really about their shape or surface contour. It will give us an indication of the diameter. We can use our calipers to measure the stone. It will give us an indication of number, although it might be slightly less accurate than radiography for that. And it too can diagnose stones within the kidneys, ureter, bladder, and urethra, although obviously less sensitive in the ureter and urethra, which may be due to, in part, operator experience. And as far as the urethra is concerned, clearly there are parts of the urethra that we just can't see with ultrasound because it's contained within the bony cavity of the pelvis. So let's look to ultrasonography first. What we expect to see with a bladder stone is a hyperechoic structure, such as is shown on the image on the right-hand side of your screen. And then we have distal acoustic shadowing. So we can see this cone of darkness underneath the stone, which tells us that this is a solid structure. This is mineralized. This is something solid. And ultrasonography, as I've mentioned in the previous slide, can also identify stones in the kidneys, ureters, and urethra, although the urethra may be slightly more complex because of its position, and we may not be able to see the full extent of the urethra. So let's talk first about the clinical consequence of uroliths and what they can actually do. Well, the most common presentation is probably that of hematuria. But we can also get animals presenting either with stranguria, difficulty urinating, or it can be an acute obstructive disorder where the animal presents in shock due to an inability to empty its bladder due to obstruction of the urethra, for example. So these animals will often present in shock. they'll often be azotemic, and they'll often be hyperkalemic. And if the animal does present in this state of shock due to an obstructive process to its bladder, then it's absolutely essential that we stabilize these patients prior to attempting to remove the obstruction using, for example, anesthesia or any form of surgery. It's also very likely that analgesia will be necessary because it's often very uncomfortable having a stone anywhere in your urinary tract, and certainly if the patient is obstructed, that's going to be acutely painful.